Welcome to the Deep Dive, your shortcut to being well-informed. We take complex subjects, distill them down, find those essential insights. Today, we're delving into a condition affecting, well, hundreds of thousands globally each year. It's a challenge rooted right back in the earliest, most delicate stages of human development. Think of it, the human body is this absolute masterpiece, right? But sometimes, even the most intricate blueprints can have, let's say, a minor misprint.
That's a good way to put it.
So our focus today, cleft lip and palate. And to navigate this really important and often misunderstood topic, we've been deep in a foundational medical chapter. Very comprehensive source.
Yeah, it covers everything. Anatomy, history, genetics, treatment, the work.
Exactly. So our mission here, for you listening, is to give you a really clear, expert-guided understanding. What is cleft lip and palate? How's it treated? And what's that incredible journey like for kids and families? We want to cut through the complexity.
Absolutely. Highlight what's vital, because this source, it really paints a picture of the dedication required in this field.
Okay, so let's start with that big picture then. What exactly are we talking about? Cleft lip and palate.
Well, fundamentally, these are deformities that happen because of a failure of embryologic fusion.
Fusion, like things not joining up properly.
Precisely. Imagine the face and mouth forming from several distinct sort of growth areas, like puzzle pieces needing to fit perfectly. If they don't join up right during fetal development, you get a cleft.
And it's common.
It is. It's actually the most common major congenital craniofacial abnormality. Affects roughly 1 in 700 live births worldwide. That's a lot of families impacted.
Wow, 1 in 700. That's significant.
And what's truly fascinating here is just how critical the timing is in fetal development. It's incredibly precise.
How so?
Well, the face and palate don't just appear, they literally fuse together. So around 6 weeks into development, you have these prominences, we call them. Median nasal, lateral nasal, maxillary prominences.
Okay, building blocks for the nose and upper jaw.
Exactly. They need to come together to form the upper lip and the front part of the roof of the mouth, the primary palate.
Right.
Then just a couple of weeks later, say around 8 weeks, the palatal shelves, these are like 2 outgrowths from the sides they need to elevate and fuse with the nasal septum. That forms the secondary palate, the back part.
So 2 critical moments.
2 critical moments. And if that delicate process gets disturbed at either point, that's when you see clefts. Complete, incomplete. Depends on the disruption.
It sounds incredibly precise. So why does it go wrong sometimes? What causes these disruptions?
Yeah, that's the million-dollar question, isn't it? And the source makes it really clear. It's usually not just one single thing. It's what we call multifactorial.
Meaning lots of factors.
Exactly. A complex interplay could be chemical exposures, radiation, maybe maternal hypoxia, certain drugs, teratogenic drugs, nutritional deficiencies, even physical obstruction in the womb. And all this alongside genetic influences.
So rarely just one smoking gun.
Very rarely, often a confluence of issues. There's this idea called the threshold theory.
Okay.
It suggests you might have a certain genetic predisposition, and then environmental factors stack up, pushing you past a threshold where normal fusion just fails.
So it's like a combination lock, almost.
Kind of, yeah. Which highlights why prevention is so complex. It's not just one fix. And while it's not usually a single gene disease, genetics are definitely part of that mix. You know, genes like MSS, LHX, they're involved in guiding development. If their instructions get a bit garbled,
things can go awry.
Right.
And these clefts, they don't all look the same, do they?
Not at all. Hugely varied. Can be unilateral one side or bilateral both sides. Might just be a tiny notch, a microform, or incomplete, or a complete cleft running all the way through.
It can involve the lip, the nose, the palate, combination.
Any combination, yeah. Lip, nose, primary palate, secondary palate. For really severe facial clefting, specialists use detailed classification systems like Tessier's system to map them out precisely.
Are there patterns, like are sometimes more common?
There are, actually. Cleft lip, more common in males. Left-sided clefts are more common than right. Unilateral more common than bilateral.
Interesting.
An isolated cleft palate, without the lip involved, that's about 1 in 2,000 live births. We also see some ethnic differences, higher prevalence in Asians, lower in African Americans.
And sometimes it's part of a bigger picture. Syndromes.
Exactly. That's a crucial distinction. Many clefts are isolated, non-syndromic, but some are part of syndromes like Stickler's, Van der Waals, DeGeorge. Early diagnosis here is vital.
Why is that?
Because it flags potential other issues. Like in Stickler's, there's a risk of retinal detachment. You need to know that early to prevent blindness. It changes the whole management plan.
Right. That makes sense. This really brings home that it's not just a single event. It's a lifelong journey for these families.
It absolutely is.
And here's where, for me, it gets really interesting. The source just hammers home the need for a team, a comprehensive, coordinated, interdisciplinary team.
Oh, completely essential. For an ideal outcome, you need that care from infancy right through adolescence. It's a long haul.
And who's on this team? It sounds like a lot of people.
It is. You've got oral and maxillofacial surgeons, otolaryngologists, ENT, doctors, geneticists, speech and language pathologists, orthodontists, prosthodontists, sometimes psychologists, social workers, the whole roster.
Wow.
And the core objectives are clear. Coordinated care, continuity of care. Throughout growth, throughout reconstruction, the best outcomes happen when the team is focused on the patient and family, not surgeon ego or specialty silos.
That sounds ideal, but are there challenges to that?
Oh, sure. The source mentions them. Competitive interactions between specialties, economic factors that can get in the way. But the key is always putting the child's needs first. That's what makes for healthy team dynamics.
And the goals. They're not just about closing the gap, are they?
Not at all. That's a huge point. Yes, you want normalized aesthetics of the lip and nose, an intact palate, absolutely.
But there's more.
Much more. Normal speech, language, hearing, a clear nasal airway, proper occlusion, how the teeth meet for chewing, good dental health, and maybe most profoundly, normal psychosocial development.
Enabling the child to thrive in every way.
Exactly. Not just physically. It's about their whole life not being defined by the cleft.
And this journey can start even before birth now, with ultrasound.
Yeah, modern ultrasound is amazing. We can often see a cleft lip as early as 16 weeks. Palate's trickier to see prenatally. It's further inside. But seeing the lip, that gives families time.
Time to prepare.
Right. Prenatal consultations become vital then. An experienced surgeon can explain the diagnosis, walk through the stages of reconstruction, talk about practical things like feeding.
That must empower parents, reduce fear.
Hugely. Knowing what to expect makes a massive difference. And having a geneticist involved early is important too, to check for those associated syndromes we mentioned. It could impact delivery plans even.
Okay, so let's talk about those early challenges. Feeding sounds like a big one.
It can be, definitely. Infants with just a cleft lip can often breastfeed okay, but with a cleft palate, it's much harder to form that seal needed for suction.
Eating too.
Inefficient feeding. They work really hard but don't get much milk, and often nasal regurgitation milk coming out the nose. It can be distressing for everyone.
So special equipment is needed.
Often, yes. Specialized nipples, squeezable bottles that minimize the baby's effort. It's a practical, day-to-day challenge right from the start, before any surgery.
Is there specific advice for parents on feeding?
Yeah, the source gives some guidelines, generally 2-3 ounces of milk per pound of weight per 24 hours. And keeping feeding sessions under, say, 35 minutes. Longer than that, they can burn more calories than they take in.
Right. Too fatiguing. What about breastfeeding? Is it possible?
It's complex. Breastfeeding has clear benefits, immunologic, bonding, but the feeding difficulties with a palate cleft are real. So often a combined protocol is suggested. Try nursing, but supplement with pumped milk in those specialized bottles. And monitor weight gain rigorously. It's about balancing benefits and practicalities.
Understanding those early hurdles really makes you appreciate the history of how we got here, the innovation. It's remarkable.
It really is.
You mentioned the source covers history. Any highlights, like when did repairs start?
Well, get this. The first documented cleft lip repair was in China, way back in 390 AD, on a patient who later became a governor general.
390 AD.
Yeah.
Incredible. So people have been tackling this for centuries.
It's a very long time. Then fast forward, 1766, Paris, a dentist, Lemonnier, credited with the first successful cleft palate repair.
A dentist? Interesting.
Yeah, and in the U.S., you had figures like Holohan, the father of American oral and maxillofacial surgery, publishing on comprehensive care, and Robert Ivy.
He sounds important.
Very.
Right.
Early 20th century. An oral and maxillofacial surgeon, also dual qualified in plastic surgery. He pioneered the first interdisciplinary teams and clinics in Pennsylvania. Really laid the groundwork for that team approach we just talked about.
Recognizing it needed multiple experts.
Exactly. And the surgical techniques themselves, they evolved hugely. From basic straight line repairs, which didn't always look great,
Right.
to much more sophisticated stuff. Then in the mid-1950s, Ralph Millard came up with his rotation advancement technique for the lip.
And that was a big deal.
It changed cleft repair forever. That's what the source says. His technique allowed the incision lines to fall within natural contours, made a huge difference aesthetically. It's still widely used or modified today.
Amazing. What about other areas? Bone grafting.
Yeah, that's another fascinating evolution, a real learning curve. In the 50s, there was this idea of primary bone grafting, filling the gap in the upper jaw early on.
Sounds logical.
It did, but it turned out to have unfavorable outcomes,
Mm-hmm.
negatively affected facial growth, so it was largely abandoned.
Mm-hmm. So what replaced it?
This connects to the bigger picture of evidence-changing practice. Early 70s, Boyne and Sands oral and maxillofacial surgeons published on secondary bone grafting.
The secondary meaning later.
Exactly. Taking small bits of the patient's own bone, usually from the hip, and grafting it later, during the mixed dentition phase when kids have baby and adult teeth.
And that worked better.
Much better. Favorable outcomes, without messing up growth. That became the standard approach pretty much worldwide, a direct result of learning and research.
Wow. Any other major surgical advances?
Orthognathic surgery, jaw surgery, big leaps there too. In the 70s, Bell pioneered the total maxillary osteotomy, the Lefort the Cerf.
Okay, what did that allow?
It provided the biological basis to safely move the entire upper jaw forward. Revolutionized correcting those midfacial deformities common in cleft patients, gave them a much more balanced profile.
And others built on that.
Yeah, people like Posnick, another dual-qualified OMFS surgeon, made huge contributions to the skeletal reconstruction techniques and ensuring long-term stability after these big jaw moves.
So all these efforts, the specialized training, they really cemented the role of certain specialties, like oral and maxillofacial surgery, in this comprehensive care.
Absolutely. Ensured a coordinated, specialized approach.
Okay, so we have the history, the team, the goals. But how do surgeons actually decide when to do what? Timing seems crucial.
It's perhaps the core challenge, balancing functional needs, aesthetics, and crucially, ongoing craniofacial growth. Operate too early, you might restrict growth. Operate too late, you miss windows for speech development, for example. It's a delicate balance.
So it's staged, done in steps.
Yes, typically. Cleft lip repair, generally around 3 months old, after 10 weeks. Historically, the rule of tens guided this 10 weeks, 10 pounds, 10 hemoglobin, mostly due to anesthetic risk.
But anesthesia is safer now.
Much safer, even earlier. But there's no real measurable benefit to doing lip repair before 3 months. Might even lead to more scarring or less ideal aesthetics if done too early. So 3 months is still the standard.
Okay, what about the palate? You said that timing was tricky.
Very tricky. Usually repaired between 9 and 18 months.
Why that window? Why not earlier?
It's that balance again. Repairing the palate too early, especially before 9 months, is linked to a much higher rate of maxillary hypoplasia, the upper jaw not growing enough, leading to that sunken mid-face look.
Right.
But you need an intact palate for proper speech development, usually by 18 months. So 9, 18 months is the compromise. Minimize growth restriction while enabling speech.
Makes sense. What about other surgeries?
VPI surgery, velopharyngeal insufficiency for hypernasal speech, that's usually 3 by 5 years or later, depending on speech. Bone grafting for the alveolus, the gum line gap, that's typically 6 to 9 years. Timed with dental development just before the canine teeth erupt, again, avoiding earlier growth restriction.
And the bone comes from the hip, usually.
That's the gold standard, yeah.
Mhm.
Autogenous bone from the anterior iliac crest.
And the big jaw surgeries, orthognathic surgery.
After skeletal maturity, so 14, 16 for girls, 16, 18 for boys, typically. You can intervene earlier for severe cases, but it might need revision later.
And final touches, lip and nose revisions.
Usually after age 5, but ideally after the jaw surgery and skeletal maturity. You want to avoid multiple early revisions because scarring can impair growth.
So a long, carefully staged process.
Very much so. And there are controversies even within that, like staged palate closure, soft palate early, hard palate later. Some advocate for it to balance speech and growth, but most North American speech pathologists prefer single stage. It shows there's still debate.
Let's dig into some of those debates and details. Pre-surgical taping and orthopedics PSOs. What are those?
These are things like elastic taping across the lip or custom acrylic devices inside the mouth, like the Grayson NAM appliance or the Latham appliance. The idea is to reshape tissues, align segments before the main lip surgery.
Sounds like it could help, doesn't it?
Well, here's what's fascinating and maybe counterintuitive. The source points to a lack of strong clinical evidence that these things offer measurable long-term improvements.
Really? Despite the cost and time.
Exactly. No clear long-term benefit shown for aesthetics, dental arch form, tooth survival, or speech. It's a crucial insight. More intervention isn't always better. You have to question the long-term benefit, especially with growth involved.
Is there any downside?
Well, the Latham appliance specifically was shown in studies to cause 100% mid-facial growth restriction later on, compared to maybe 25-35% restriction in kids who didn't have it.
Wow. That's a huge negative impact.
It really illustrates that complex balance and potential unintended consequences.
Okay, what about lip adhesion, another preliminary step?
Yeah, sometimes used for very wide clefts. A simple surgical tacking down first before the definitive repair. The idea is to narrow the gap.
Does it work?
The source suggests it rarely converts a wide, complete cleft to just an incomplete one. And the scar from the adhesion can actually make the definitive repair harder later. Tissues are less supple. Often, it's better to just mobilize the tissues well in one go.
So for the main unilateral lip repair, what's the goal?
Meticulous three-layer closure. Skin, muscle, mucosa. And crucially, reconstructing that orbicularis oris muscle, the mouth muscle, into a functional ring.
And the Miller technique is still king.
Still preferred, yeah, because it hides scars in natural lines. And primary nasal repair is often done simultaneously, gently repositioning cartilages with minimal dissection to limit scarring that could affect growth. McComb's technique is one example.
Bilateral lips. You said they're more challenging.
Often considered one of the toughest procedures, yes. Lack of quality tissue, displaced segments, often a really short columella that bit between the nostrils.
Any pitfalls to avoid?
The source cautions against overly aggressive techniques trying to lengthen the columella or save underdeveloped tissue. They can apparently result in an abnormally long and excessively angular look later, which is really hard to fix. Iatrogenic problems caused by treatment.
Right. Okay, shifting to palate repair techniques. Goals there.
Two main goals. One, watertight closure of that hole between the nose and mouth. Two, anatomic repair of the soft palate muscles, especially the levator palatini.
Why is that muscle so important?
It's key for speech. You need to disinsert it from its abnormal attachments and reconstruct it in the midline to create a dynamic sling. That sling function is what closes off the nose during speech, preventing hypernasality.
And how do surgeons do that? Different techniques.
Several common ones. Bardock, two-flap, von Langenbeck. They involve moving flaps of tissue. Then there's the furlough double opposing Z-plasty, which tries to lengthen the palate too.
Any clear winner among techniques?
Interestingly, no. The source states pretty clearly that no single technique has convincingly shown superior outcomes across the board for dental arch form, speech, or feeding. Surgeons often rely on their training and experience. Definitive comparative data is lacking.
That's a really important point about the state of evidence.
It is. And then you have the really complex facial clefts. Much rarer, much harder.
Caused by similar things. Fusion failure.
Can be fusion failure, physical obstruction, amniotic bands. And they bring unique functional issues, like tessiator no. 7 clefts affecting the mouth muscle, needing early repair for feeding. Or orbital clefts involving the eye socket.
Requiring immediate eye care.
Absolutely critical. Eye lubrication, maybe temporarily stitching the eyelids partly closed tarsorrhaphy to protect the cornea from damage, even blindness. These cases really underscore the need for immediate, specialized, coordinated care.
Which brings us back to a critical theme. The need for evidence.
Yes, the source really stresses this. Despite decades of practice, there's a surprising lack of rigorous evidence-based research to guide many clinical decisions in cleft care.
So we need to move beyond just anecdotes.
Exactly. Critically review outcome studies, not just rely on surgeon enthusiasm or experience, especially with healthcare costs being what they are. As patients, families, we should ask for evidence. As a medical community, we need to generate more of it.
And measure outcomes comprehensively.
Right? Not just surgical healing, but long-term. Appearance, facial growth, occlusion, patient satisfaction, psychosocial development, the whole picture.
Looking at the whole person.
The ideal, as the source puts it, is care that's free of bias, patient, family, community-oriented, focused on maximizing the patient's ability to grow up, succeed, and not be defined by their deformity. Empowering them.
What an incredible journey we've taken through this. The embryology, the lifelong care, the history, the surgical nuances, the vital need for teams and evidence.
It's a complex world, but filled with dedication.
Absolutely. As you listening reflect on this, maybe consider how these breakthroughs in understanding development keep reshaping lives, and what new frontiers might emerge. Personalized care, earlier prediction, or intervention. How do we balance that potential with the delicate reality of growth?
Big questions for the future.
Indeed. We hope this deep dive has given you a clearer, more informed perspective on this remarkable field.